everyone, I am Dr. Vijay Bang. I am President-elect of Cardiological Society of India and Chairman of the Scientific Committee for Cardiological Society of India Annual Conference, scheduled to occur on December 8 to 11 in Chennai at Chennai Trade Center. I welcome you all and invite you to join in large number at Chennai for the annual conference. Today, NIC sessions are going on for next 2 days more, and I have delivered one talk on left main disease, PCI versus CABG. Have we got finally the answers? And in that, I would like to say that the conclusions, on the conclusions point, I would like to speak that for selected cases of left main, PCI is a good alternative, and it remains there as per the guidelines described in 18 and 21. Both ACC and ESC, both guidelines agree for the class 1 for 0 to 22 low syntax score. For intermediate syntax score, it is 2A, and for PCI, and the 3 for the high syntax score, whereas CABG is 1 and a level of evidence A for both the panels. So that remains, but we have to select cases, avoid diabetic cases, particularly insulin-dependent diabetic cases, because if you see the complete individual patient data meta-analysis report, it suggests that the cumulative mortality in diabetic was little higher, significantly higher compared to the CABG arm in the PCI arm. So we have to avoid complex high syntax score, that is 33 and plus, and diabetic. That we must avoid. We should not offer PCI. And in fact, those who are prohibitive for the surgery due to high ST score with a left main and triple vessel disease, there we should do a trial comparing PCI with current modern OMT, optimal medical therapy. And that is when we will come to a conclusion, and we should plan a larger PCI in the left main with multivessel disease, using FFR and with the modern technology of the stent. And that should be a prospective trial comparing the two, because earlier trials like Noble, these trials did not use the latest stents. So it's better to try with the latest stents, second generation, third generation stent, using FFR. As per the FAME3 result, if you compare data of CABG in PCI and FAME3, if the FFR value is significant, then 0.8 or lower, then you should consider PCI for that vessel. If it is more than that, then you should not do PCI for that patient. So these are some of the important aspects that we have to take into consideration to provide excellent long-term results for all these patients. So it becomes very, very vital how we choose our patient, keep the patient in the center, use heart team approach, declare patient that there is a probability of 0.2% per year mortality in PCI arm compared to CABG. That we should tell upfront, no harm in telling the patient, but that is only for the diabetic subset mainly. If the patient is not a diabetic, your results are almost equivalent to that of CABG. So keeping all these factors and plus comorbidity of the patients who are subjected to PCI in left main disease, we have to keep in mind those things also, because that comes to the syntax 2 and syntax 3, we should look into all these aspects of, and I suggest that everyone should download the syntax app and count syntax score in each and every patient. And according to the syntax score, please offer PCI to the patient. You will never repent. Your patient will be happy and will get a good, excellent long-term result. This is my message for considering PCI in left medicine. Thank you for kind attention.